a postdoc at Stanford University, as well as being a lecturer here at UC Berkeley in our School of Public Health, teaching social epidemiology this spring, I believe. Is that right, Tracy?
That's right.
Yeah.
Yeah. Yep.
So yeah, thanks so much for joining us. I'm really excited to hear about your research. I hand it over to you.
Awesome. Thank you so much, Jen. Let me just put up my slides really quickly. Can folks see the slides? Okay, great. I'm going to just rearrange things here a little bit. Okay, great. Well, hi, everybody. Welcome and thank you for tuning into my research talk today. And thanks to Lauren, Jen, and all the others who made this opportunity possible to present. My name is Tracy. I'm currently a postdoc, as Jen mentioned, in epidemiology and population health at Stanford and a lecturer in Division of Epidemiology here at Berkeley Public Health. I did do my doctorate here at Berkeley Public Health, where Amani was my dissertation chair and Corinne Riddell and Patrick were on my committee. So it's nice to be back here in the place that helped foster a lot of these ideas in me. Today, I'll be sharing some of the highlights from a recent perspectives paper that I first authored that was just published in the Milbank Quarterly about just 2 weeks ago. And in this paper, we offer up a reflexive framework to promote health data equity for the US multiracial population. Sounds like a lot. I'll talk about what all that means. But for here, kind of, and going forward, I define multiracial as people who self-identify with more than one race. And this is not an empirical piece, so I'm planning to first touch on some of the historical background to motivate this paper and kind of talk a little bit about the state of research as it is right now, and then try and highlight some of the main areas and recommendations that will be probably most of interest to this audience. So first, I just want to acknowledge my co-authors on this paper who I met through last year's SER, or Society for Epidemiologic Research meeting in Portland. We are a group of multiracial epidemiologists, and we decided it was about time for a piece like this to be written and published and shared with a public health audience. And I think given the topic, it's important for us to share our positionalities in relationship to the topic. And I'm also just really grateful, I want to say, to the Milbank Quarterly for letting us add in a set of positionality statements, which I think is pretty rare for authors in health sciences and policy journals. Okay, so on to some background and history first, I'll start with. I also want to say that I'm going to give a content warning that not this next slide, but the one after it has some artistic depictions of racialized sexual and physical violence. So if you need to tune out momentarily while I cover that slide, please feel free to do so. So first, this is, I think, a wonderful image of, I love this image, of Mildred and Richard Loving, taken by Gray Villette, who was a photojournalist who covered the couple's legal battle against the state of Virginia, which ultimately resulted in the 1967 Supreme Court ruling in Loving versus Virginia, which overturned anti-miscegenation laws, or laws that banned interracial marriage, which were still present in 17 states in 1967, mostly in the South. And I think it's important to note some timescale here, because it's been still to this day less than 60 years since that decision legalized interracial relationships. But the longest of these bans was the law in Virginia for over 400 years. So in terms of timescale, it's quite a big difference. And so again, compassion alert for the upcoming slide. Feel free to just kind of look away if that's what you want. And so while interracial relationships were outlawed for over 400 years, we know that multiracial populations, at least in the current sense, have existed on this continent since colonization. And keeping with the theme of Virginia's central role in US multiracial history, this is a painting titled Virginian Luxuries, dating to 1825 from an unknown artist, likely based in New England. It was an early artistic work that both depicted the really violent and twisted horrors and excesses of slavery in the US South, and also the origins of some of the earliest multiracial populations in the United States. And I think it's helpful to take a historical perspective on things, because despite the relative invisibility of multiracial populations today, we know from historians such as Aaron Wilkinson that, in fact, multiracial populations were integral to the creation of a racially stratified and white supremacist colonial society, and acted as a buffer really between enslaving and enslaved groups. And so over time, racial classification laws emerged to oppress multiracial populations into subordinate positions and kind of help facilitate some of that erasure through till today. And I'll talk more about that on the next slide. So this is a great figure you may have seen produced by the Pew Research Center, which shows the change in racial categorization schema over time in the US Census. It's maybe a little bit hard to see here, but for the first 60 years or so of the census, race data was not actually collected. It was just based on enslavement status. And it wasn't until the 1850 census when they first transitioned to racial group data collection, which divided the population into white, black, mulatto, which generally referred to people who were multiracial black slaves, and mulatto slaves. And while the census had these kind of separate categories for enslaved and non-enslaved folks, as well as monoracial and multiracial Black individuals, the practice of what we call hypodescent, which is now more commonly known as the one-drop rule, meant that individuals with any Black ancestry, such as fun terms called quadroons and octoroons in the 1890 census, it's just some of these terms are almost ridiculous at some point. Those folks were also assigned Black race and accordingly socially and economically subjugated. And even today, blood quantum laws also function very similarly to limit indigenous sovereignty to the present day. The one-drop rule is also one very obvious example of the persistent link between structural and cultural forms of racism and individual-level racial identification. As a large part of the Black population that has multiracial ancestry continue to be assigned and also self-identify as monoracial Black. And it wasn't until the 1997 that the US Office of Management and Budget, or OMB, decided to require federal agencies to let people select more than one race on federal categorization forms, which was finally reflected in the 2000 census and in the current sort of 7-category system that we use today. So today, by 2020 census counts, the multiracial population is now actually the 4th largest racial or ethnic group in the country, behind white, Hispanic or Latino, and Black populations, with 1 in 10 residents in the United States self-identifying as multiracial in the census. And if, the census notes that this is not all real demographic growth. This is this change in the last 10 years does reflect a change in the way that the questions were asked, and is not really just totally driven by growth in the population. But I also want to just bring this up and focus on population size, because I still hear it. It's a common dismissal of research on multiracial people, which I'll kind of go into more in a few slides, is that it's too small of a population to focus on in public health. And I want to clarify that I very much disagree with that premise, that there are any populations whose health, or populations that are too small for their health to be worth focusing on. But also, this is just not a small population, period. Like 34 million people is not a small population. So now I'll move on to talking about the state of contemporary research on the health of multiracial people in the US. So both the racial categories and the inequitable gradient of health across them in the US have arisen, of course, from structural racism, which continues to concentrate advantage in the white population at the expense of racially minoritized communities. And while we normally talk about health inequity in relation to monoracial groups, multiracial people also face major disparities in a wide variety of health outcomes, including some of the highest rates of any racial group of adverse childhood experiences, asthma, obesity, substance use, mental illness, hopeless feelings, as well as serious psychological distress. Now, a lot of my colleagues who study multiracial people are actually in social psychology and education and other fields, and there's definitely a push, particularly from psychology, I would say, away from deficit-based framing and towards asset-based framing, which I think is great. But I also think it is important to not gloss over health disparities where they exist, and perhaps instead of framing them as deficits to a population or an identity or something like that, to call attention to the social and structural forces that reproduce those disparities. And so, given the fields from which research on the multiracial population has arisen, a lot of it has really focused to date on individual level attributes and processes that are kind of individual level attributes of multiracial people, such as racial identification and socialization. And I would say there's comparatively less research that's focused on the structures and patterns of social stratification that affect multiracial populations, which is, there's growing awareness that these things really matter for public health, and also acknowledgement that multiracial people have distinct identities and racialized social experiences from monoracial people. But as you'll see in the next couple of slides, I would say that like conceptual and empirical work and research in public health and medicine has not quite caught up with that awareness just yet. So when I was getting ready to apply for my NIHK award last summer, I did a search of funded grants in the NIH Reporter and found that about 1,000 had titles. So about 1,000 grants had title or keywords matching specific racial or ethnic groups. So Black or African American, Hispanic, Latino, Chinese, Mexican. I used all these search terms in the search. And of those 1,000, only 2 matched multiracial or biracial or mixed race. And that's not including terms like a multiracial cohort or a biracial cohort, which is not really about multiracial people. And 9 matched the term admixed, which I'll note here that we discourage the use of the term admixed when describing race because it refers to genetic ancestry, not race. And when I was writing this manuscript, I replicated this title abstract keyword search in leading public health and policy journals and found an earth-shattering 11 articles, 7 in AJPH, 3 in the entire JAMA network, and 1 in the Lancet. There were both 0 in the Milbank Quarterly and Health Affairs, but I decided to bump Milbank up to 1 since this paper is now published in that one. So great, they have 1. But I really want to just kind of point this out because I think the size of this population and the health need facing this population and the lack of literature describing it is just really striking to me. And so I also wanted to kind of clarify what I mean by health data equity as I refer to in the title. Well, it certainly does not look like the last 2 slides, I would say. But I define it as health data equity occurs when data systems and structures and the language used in them enable full and accurate depiction or description of health status and disparities across all communities in our population. Working towards data equity requires socially marginalized communities to be involved with the production, analysis, interpretation, and the dissemination of health data. And this is kind of my own words, but it draws on earlier definitions from others, in particular Inez Ponce at UCLA, who heads up the CHIS, or the California Health and Review Survey, and has written a lot about health data equity from the Native Hawaiian, Pacific Islander, and Asian communities' perspectives. All right, so introducing our framework. Let's just get to it. Now, I'm sure there's probably some selection effects at work here in this audience, and if you're showing up to this talk, my guess is you're probably already interested in health equity and maybe you're here to learn how to improve your work in this area or just to kind of learn more about this. And so this framework is meant for people like you. Perhaps you've asked yourself some of these questions, like what do I do about multiracial people and where do they fit into my work? How do I categorize them? And that is actually the exact line of questioning that got me interested as a multiracial person myself in this area. So we're all in good company here. I want to note that our framework draws on 2 major critical approaches. The first is critical mixed race or multiracial studies, which is a branch of critical race theory that centers the multiracial experience. If you're interested, there's a whole conference around it. It's actually happening this summer in Ohio. It's every 2 years. And also the critical race public health practice as described by Chandra Ford and Collins Arian-Bua. And this paper in particular draws on the practice of disciplinary self-critique and the action focus of that public health praxis, critical race public health praxis framework. I also want to make it clear that this framework doesn't ask anybody to upend their work to focus solely on multiracial people. That's just like not realistic and not our goal. But instead, we want folks to engage with intersectionality practice, which critical race scholar Mari Matsuda summarizes nicely in this quote, which the way I try to understand the interconnections of all forms of subordination is through a method I call ask the other question. When I see something that looks racist, I ask, where's the patriarchy in this? When I see something that looks sexist, I ask, where is the heterosexism in this? When I see something that looks homophobic, I ask, where are the class interests in this? So we would additionally add that folks ask themselves, when I see something that looks like racial health inequity, where or how are multiracial people erased or oppressed in this? Okay, so our framework consists of 3 questions. Question 1, which really lays the foundation for 2 and 3, asks readers to self-examine their implicit biases or assumptions about the multiracial population. Questions 2 and 3, which more directly concern research approaches, ask readers to think about which categorization approaches most support health data equity for the multiracial population. and other populations, and also what daily activities, if any, that they engage in that promote institutional monoracism or erasure and inhibit health data equity. And I'll talk a little bit more about what monoracism means in a slide or two. I also want to note that I'm choosing to focus more on questions 1 and 3 for this presentation, as they're a bit more like concrete. And I think, question 2 is a little bit more focused. The way you engage with question 2 will depend on your research question at hand and sort of what you're thinking about and what you're looking at. And so I would suggest reading the paper to kind of think more about those categorization schemes a little more critically. All right, so question 1. Let's first start with examining some implicit biases or assumptions that we as multiracial epidemiologists often see and hear in our work. Okay, so misconception number 1, this is like a little game of trivia here. Multiracial people are a small fraction of the population, especially outside of California, Texas, or Hawaii. This is something we have often observed. And in actuality, while the absolute size is greatest in California and Texas, and the share is highest in Hawaii, states like Florida, Nevada, Arizona, Oklahoma, Colorado, Alaska, Oregon, and Washington all have a larger share of multiracial residents than the national average. So that is to say that each of those states that I mentioned, including states in the South and the Midwest, that we tend to not think about when we think about multiracial people, all have more than 10% of their population identifying as multiracial. Another misconception is that most multiracial people are white and Black or white and Asian. This one is kind of an interesting one. And possibly is actually related to this sort of understanding of the geography of multiraciality. And in reality, the largest multiracial subgroup is those with white and American Indian or Alaska Native ancestry. Often, actually, many of those live in Oklahoma. Many of those folks live in Oklahoma. American Indian and Alaska Native, as well as Native Hawaiian or other Pacific Islander groups, have the highest proportion of multiracial identifying individuals. And I think it's also important to note that the assumption that most multiracial people are part white is kind of insidious because it culturally erases multiracial people who have no white ancestry. This is a fun one. You may have also noticed this, but a third misconception that we tend to see is that folks will say, if current demographic trends continue, we will all be multiracial. And because everyone will be some shade of brown, racism will just magically no longer exist. This is a fun one because I think, this is a narrative we often see in the media, which co-opts and exploits multiraciality to create this post-racial mirage that appeals to mainstream readers' desire for this like colorblind society in the future. We're unaware of any actual true like scholarly demographic projections that predict any kind of disappearance of monoracial groups. And I think it's also important to note that racism also very much exists in countries that have built entire national identities that parallel multiraciality in the United States. For example, Mexico, mestizaje in Mexico, and racial democracy in Brazil, right? These are countries that have large multiracial populations in a similar sense, and yet racism is very, very much apparent in those societies as well. And so I think the danger of this narrative is that kind of distracts from the need for these important racial health equity and other racial justice programs, which, if history is any indication, we will still need in the future. And here's some fun screenshots of actual news articles. This I don't know, this one from 2019, it's not even that long ago in the New York Times is an opinion article that says, want to be less racist? Let's move to Hawaii because everyone's multiracial there and the aloha spirit can teach us that racism will go away. Or even this one from the Greater Good Research Center here at UC Berkeley asks us, can biracial people help all of us be more open-minded, right? So again, kind of using multiracial people to help solve or fix racism, which is a very troubling, I think, approach because it kind of focuses on one group rather than the structures and the systems that perpetuate inequity. And then lastly, misconception 4 is that racism shapes people's experiences. Well, that's true. But because multiracial people are less of any of their given races than monoracial people, they do not experience racism as much as monoracial people. And it is true that some multiracial people may not face the same amount of discrimination as monoracial people from particularly marginalized groups because of passing privilege or skin color or racial ambiguity. However, multiracial people do experience racism, including in other forms of racism, which I kind of mentioned earlier. I alluded to the term monoracism, which I'll talk about now. So monoracism is a concept that was introduced, at least first that I know of, by Mark Johnston Guerrero, and Kevin Nadal in 2010. And it is really described as the variant of racism that systematically privileges single race identification and erases multiracial people's experiences. And there's, like regular forms of racism, multiple levels. It can be observed in institutional, everyday, and internalized forms. And I just wanted to go through this again because I think this is important for folks to kind of be aware of and know. I'll talk about institutional and kind of everyday experiences of monoracism here briefly. Institutional monoracism has shaped our kind of preference for conceptualizing race using mutually exclusive categories. And it can look like some of these things. So electronic health records that in the 2020s, no less, are still not programmed to handle multiple race selections. The entire healthcare system that serves veterans in the United States cannot handle multiracial selections. So that's that. Monoracially organized student recruitment and retention centers on college campuses. I will talk more about this later. These are very important. I do not want this to be misconstrued that these kinds of organizations are not important, because they are. But I think I'll talk a little bit later about what we mean when we say race conscious, and the fact that race conscious needs to be conscious of all racial groups, including multiracial identities. As well as studies in the literature, academic and scientific literature, that pathologize rather than contextualize the impact of multiracial identity on health, right? So to the extent that this idea of an identity impacting your health is true, we want to contextualize that kind of thinking rather than pathologizing it. And so on the everyday level, these are things that I've experienced myself and others. So there's plenty written about in the literature. These are often also termed multiracial microaggressions. And some of them can look like multiracial adolescents having to defend the authenticity of their racial identities to monoracial relatives or peers, multiracial people allowing others to view them as monoracial to avoid confusing or drawing unwanted attention from others, TSA agents flagging parents of multiracial children as suspected sex traffickers. I think this happened like 4 times in 2023. Like there were 4 news articles that reported on this. So it happens, and it happens still today. Healthcare professionals making inappropriate assumptions or comments about a multiracial patient's racial background, a fetishization and exotification of a multiracial person's physical appearances. And so all these things are kind of essentially microaggressions that people are dealing with on the daily. And I would say some of these are macroaggressions, actually. I don't think it's too much of a stretch for folks who think about this kind of work to understand how this form of racism, monoracism, can really negatively impact multiracial people's racial identity development and socialization, which is an important protective factor for other racially minoritized groups. And without a ton of multiracial communities out there to support, and a lot of monoracial people being privileged to be unaware of these experiences, these harms are oftentimes born in isolation, which makes it doubly hard. Okay, now that we're through the sort of misconceptions, assumptions, lack of understanding, we've covered all that. We encourage people to kind of continue to reflect on these, and we understand that these are not these assumptions and misconceptions are not intentional, but as health equity researchers, professionals, we have a responsibility to really uncover those biases and understand where they impact our work. Okay, so kind of continuing a little bit on the idea of biases. Question 2 asks, what approach to categorizing multiracial people maximizes health data equity in your work? And so I'm going to spend a little bit less time talking about this question, but I encourage you to read the paper because it's an important one. And I do want to say kind of in advance that, examining differences across social categories such as race, gender, SEP, socioeconomic position, is central to the practice of health data equity. But of course, a large body of evidence points to the threat of misclassification of these variables, on internal validity and introducing sort of bias, right? Including a paper I helped co-author in AJE on this specific topic. But internal validity aside, an analyst's choice of how to categorize people is not neutral and oftentimes requires like strong and really hard to test assumptions. It may have deep socio-political impacts, implications, and actually meaningfully impact your study results. But despite this complexity, oftentimes health researchers and analysts kind of just do this task routinely without really thinking critically about it. So here's a list of some commonly observed strategies for categorizing multiracial people, organized in sort of ascending order of the amount of information we get about multiracial groups. And these include sort of from worst to best, completely excluding from data collection or analyses. Here, we no new information is gained and multiracial people are totally erased. So this is probably the worst. We don't recommend this at all. Another one might be reclassifying multiracial people into the like some other race or just like other category, which we, again, generally recommend because using other as a category doesn't really have any meaningful interpretation associated with it. Number 3 is reassigning into one monoracial group based on like some kind of investigator created algorithm. And this might be, making assumptions about how people choose to identify. And so there's definitely some, I think, strong, maybe potentially untestable assumptions here. But depending on the algorithm, it might reflect racial hierarchies that are worth studying. Number 4 is reassigning into each of the monoracial groups that a multiracial person self-identifies with. So if I'm white and Asian, then I might be reassigned into both white and Asian categories. I look monoracial in each of those categories. And this can be challenging because, of course, totals will add up to over 100%. There are ways around this, fractional assignment and things like that. But again, this literally involves splitting people into halves or parts and reassigning them to other groups, which just doesn't really feel good. Although there are statistical reasons we may do this, right? Number 5 is using a self-identified quote unquote best racial category. NHIS, the National Health Interview Survey, used to use this language, and BRFIS, or the Behavioral Risk Factor Surveillance System, still does. It has relevance for studying socially assigned race, or sort of how we are raced by others on the street. This is something that Nancy Lopez talks about, street race. Kamar Jones has written about socially assigned race. And so it is, of course, an important thing to understand sort of how we are treated based on our physical appearance. However, there's definitely issues with this language and some conceptual lack of clarity, which I'll refer to in a future slide. Number 6 is creating a separate multiracial category. And this is generally what we recommend as a bare minimum for most studies, with some major exceptions, which I'll also refer to in a minute. And then number 7 is disaggregating multiracial subgroups. And this is really, I think, probably the ideal. This is the best that we can aspire to for now. But of course, we worry about small cell sizes in quantitative analyses. And that's definitely a real thing. But we will talk about strategies to enable disaggregation in future slides. And so again, there's a lot more detail on this paper. But if there's one thing I want you to take away with from this section. In general, for analyses of using OMB 15 categories, we recommend disaggregating by multiracial subgroup. If that's not feasible, investigators should at minimum use a multiracial category. However, I mentioned there are some caveats here, right? Reassigning into monoracial groups may actually be appropriate in some cases, and that might be to avoid what Quint and Friedman and others have called data genocide, right, for indigenous groups that have a very large proportion of multiracial members. Doing so, reassigning them into those groups may actually enable more equity-focused analyses to prevent further erasure of these already marginalized populations. And doing this for multiracial Black groups can also be appropriate in studies of anti-Black racism to reflect the really enduring influence of hypodescent, or the one-drop rule, in anti-Black racism. And so, these are our general recommendations, but analysts should always consult with members of these populations and anti-racism experts to determine the appropriate approach for that specific study. And these choices should be made really carefully with active consideration of theory and history and how your study findings will advance or impede justice for marginalized groups. And again, this is kind of, I'm talking to a research audience here, but there are applications for this for policymakers, for those who design study interventions and things like that too, or health intervention programs and things like that. Okay, our final question asks, how might common activities in your work perpetuate institutional monoracism, and what can be done differently? And back to our discussion in question 1, we encourage professionals to consider how like these linguistic conventions that we use when talking about racial groups and describing multiracial people may reflect the very implicit biases that we tried to uncover in question 1 that really reflect the relative primacy of monoracial groups in our society. And so we are going to point out and call on JAMA here, call out, whatever, the Journal of the American Medical Association. JAMA released guidance, I believe I forget exactly what year it was in. This is their latest guidance, which I appreciate and we support, suggesting to avoid using the term mixed race unless it was specifically used in data collection. Like other terms that have been reclaimed by groups, multiracial people may use the term mixed to describe themselves. However, it's generally inappropriate for monoracial people to use this term in professional settings, right? It may be fine in colloquial settings or depending on the setting that you're at, but in an academic research article or things like that, we recommend avoiding using the term mixed or mixed race because of sort of the history of that term. And as an alternative, we would recommend using multiracial as maybe an alternative to also the term 2 or more races, which feels a little bit awkward sometimes. And multiracial or biracial actually refer to a social and racial identity that people actually hold. Not everybody in those categories uses that term, but at least it would be some of them. We also agree with JAMA guidance to capitalize all race, ethnicity, and tribe names. However, despite this guidance, JAMA perplexingly does not recommend capitalizing multiracial in this guidance. And I would say at best, this represents, a missed opportunity for acknowledgement and could be an act of erasure. And the alternative here is to capitalize multiracial and biracial. I would also say that we recommend in the paper that investigators, when describing their study population or their study cohort, to avoid using the term a multiracial cohort or a biracial cohort, when in fact those study cohorts are just composed of multiple groups of monoracial people, like multiple, and this is kind of a core part of health data equity as well, because doing so actually, prevents the discovery of literature and literature reviews that are of studies that are of actual multiracial and biracial people. So we recommend not using those terms. And so the final few slides I'll cover today walk through specific recommendations for researchers, policymakers, as well as practitioners in areas of their work, from conceptualization to study and program design to data analysis and communication of findings. So for conceptualizing race and multiraciality, we really recommend, again, sort of echoing what many others are kind of saying more and more loudly these days, is to be clear about the pathways that you hypothesize link race and your outcome of interest, right? There may be some statistical association between race and an outcome of interest, but what is the actual biologic, biopsychosocial pathway that links those two things? We also, kind of echoing our colleagues in social psychology, recommend avoiding pathologizing multiracial or any racial identities, right? When we assume that some health outcome or disease is associated with an identity, what are we actually saying about the people who hold that identity, right? And what is the intervention? Should we be less of those identities? Is that what we're recommending? And also to do your research on where multiracial and monoracial communities' histories and experiences intersect and where they don't, right? And so I think this is understanding some of the history that I talked about earlier, particularly for the communities, the monoracial communities that you're interested in, right? And that looks different depending on the demographic groups that you're focusing on and the geographic areas you're looking at. So in study design, we have a few different kind of phases of study design. First, we'll talk about recruitment. This one is a pet peeve of one of my co-authors, is to really state clearly if your inclusion or recruitment criteria for a study include multiracial individuals, right? I think This also will apply for another slide that I'll talk a little bit more about in policy design, but be clear when you're recruiting a study population that is racially defined, whether or not your population actually includes multiracial people or not, who share ancestry with that primary group that you may be studying. Another is to conduct power analyses to determine sufficient sample sizes for subgroup disaggregation. So we always find these studies that are saying, oh, like the subgroups are, we have small cell sizes because we didn't have enough power to disaggregate here. But I mean, power analyses are meant to actually do this specific thing. And so if we care about the differences in the heterogeneity within this population, doing power analyses to actually enable sufficient sample size for detecting those effects later on, I think is important. And also to employ targeted sampling and oversampling if necessary, right? So we see this being done in a lot of studies who may target or oversample specific racial or ethnic groups or some specific intersection of identities or characteristics. And we can also do that here for multiracial subgroups as well. And so now moving on to collecting data in study design, right? So I would encourage everybody here to think about how race is asked in survey research. And I think one thing my advisor currently likes to talk about is we spend a lot of money asking people 3 different possible ways, how many apples did you eat yesterday? And that kind of reflects, right, like the focus on these sort of proximate health outcome or proximate determinants of health. But we usually use 1, if 2 questions to assess something that is so influential and so impactful in understanding our social experiences and not determining or in our health outcomes. And so we encourage folks to ask respondent about race in multiple ways, right? So there can be your racial identity, your socially assigned race, your ancestry. And so there's plenty of different examples here that kind of get smushed into one question. But particularly if you're going to ask data on socially assigned or street race, we also recommend additionally clarifying who the hypothetical third party assigning that race is, right? So normally this is described as if you were walking down the street, what race would most people assume that you are? But for multiracial people, this may look different depending on the context they're in, right? So in some places, if you're walking in a certain community like Chinatown, you may be raised a certain way versus in more sort of other parts of the population. And so if you're going to ask about street race, then specifically say like who you think that third party assigning that race is, because it may vary depending on the situation. Also be thoughtful when collecting language or when collecting data where you're asking about quote unquote best race. Again, this is sort of like a little bit of a microaggression here. If you're going to do so, also recommend including the multiracial as a response option, because that may be someone's best race. That may be exactly how they had always been identified by other people. And also to explore data linkages to improve data quality in those data sets that don't have self-identified race. And we talk a lot about this related to death certificates in the paper. Race is assigned by third party in death, usually funeral directors. And Robert Hahn has done a really great set of studies that show that a lot of funeral directors do this without actually even consulting next of kin as they're supposed to. And one study using death certificate data by Finlay et al. In 2001 in California found that death rates for people coded as multiracial in California were 1/6 that of monoracial groups, which to me suggests that a lot of multiracial people are being routinely miscategorized in death records. But there are ways around this. And so data linkages like the census numident file, which allows individual level linkages between, in this case, death records and self-identified race, can help us reduce information bias in analyses of death certificate data. I think it's important to note that an area where we tend to see institutional monoracism lurking is in the design or policies of programs intended to improve racial equity, such as race-conscious scholarship programs or college campus support centers. And as I mentioned before, these programs are absolutely critical, and I want to make it really clear that this critique should not be misinterpreted to say that these are not important. But as I mentioned and said before, race-conscious programs should be conscious of all racially marginalized identities, including multiracial ones. And so when kind of setting these campus centers or scholarship criteria up, it's important to also consider multiracial people and where they fit in and not leave any room for interpretation in the implementation of that program or that scholarship or program policy. Also, it's important to avoid using race in decision-making algorithms for treatment or resource allocations without thinking critically about equity for marginalized groups. So our recommendations for descriptive data analyses mostly mirror our discussion of the pros and cons of different categorization approaches that we talked about in question 2. Don't think anything is new here, so I'll just leave this as it. For causal analyses, these recommendations are also not new. We don't talk about them as much in the paper, but many will be familiar with them. We support Kamara-Jones's longstanding recommendations to avoid specifying race as an exposure and instead investigate racial heterogeneity in exposure distributions and the sources of that heterogeneity in exposure. And when racism is exposure of interest, also consider the effects of monoracism and other intersecting systems of oppression like ableism, gender binarism, etc. And finally, race imputation. This one's a tricky one. It's challenging, and we devote a good amount of page space to talking about it. We need better race data to monitor racial inequities, and so I support the goal of race imputation work to enable that monitoring. However, I think it's important to really question where the benefits of going from no data to some data really just taper off. Better data isn't always just more data. Sometimes it is, but not always. And so in general, we have some recommendations for folks who deal with race imputation, which is to be judicious when imputing race and transparent about methods and their limitations. If you curate or produce data sets for secondary analyses, please create imputation flags for users to understand where race was imputed, since that's not always done. And then also to compare post-imputation and expected population distributions in a sensitivity analysis or something like that, and highlight any areas of major difference. All right, so in conclusion, I just wanted to say that population level stratification systems have created and maintained health inequities. Racism and monoracism has shaped the tools that we use to study and understand and address these disparities. And researchers and policymakers and health providers must seriously consider their responsibility to marginalized communities that have, historically and continue to be rendered invisible in health data. And to prevent this kind of erasure, we recommend engaging with these communities. And we represent, co-authors and I represent just one of these communities, but many others share our goals of health data equity. So here's a link to the paper. Feel free to pull it up right now. I think we may be able to make these slides available as well. And I just wanted to say thank you, as well as acknowledge David, Rehkopf, Elias Saperstein, and Annabelle Atkin for their helpful comments on this paper. And that's it. I welcome any questions folks may have.
Great. Thank you so much, Tracy. That was fantastic. I really learned a lot. Thank you.
Thank you. Yeah, I see Brian's already raised his hand.
Yeah, Brian has a question. And then also there's one question. Could you clarify what is meant by race imputation? But
Great. Yeah, we'll do that. Brian, go ahead.
Brian, go ahead.
Hey, Tracy. Thank you so much for your presentation. It was so interesting. I learned so much. And
thank you.
Yeah, and in my work, as you're familiar, I support youth participatory action research projects, or YPAR projects, where young people are conducting research to address issues in their schools and communities. And this current school that I'm supporting, this current YPAR project, they conducted a survey, 200 surveys, and in their sample, there's a lot of multiracial respondents, and even the high school students are asking these questions about, like, what do we do? Like, do we put them all in one category? Do we separate them out? So, we're helping them with the data analysis, and I wasn't entirely sure what to do. So I really appreciated this talk, and yeah, I was wondering if we can have the slides, or it would be great to, that graph you shared with, like, the least recommended to, that was really helpful. And I really hope to just kind of translate that for youth population. So
Yeah, no, it's a great, I mean, it's honestly, I think the question that kind of first drove me to this work, and I wish I had more time to focus on it. There's not enough in this 1 hour, but yeah, there's a table, the table 2 in the paper. I can send the paper to you. That actually has like pros and cons associated with all of those, like detailed pros and cons associated with each of those approaches that can help people kind of determine what makes sense based on the study question that you're asking. But that's really cool that you're doing that. I really appreciate that work. And there's no one right answer, I will say that. There's just trade-offs, basically. I see Amani has her hand raised. Let me just, we'll do yours and then I'll answer the race imputation question.
Oh, I can wait.
Oh, okay, sure. I'll just say, yeah, race imputation generally involves using statistical methods, a data-driven approach to basically filling in missing values for race in a data set, right? And so there's this is oftentimes used to prevent bias from being introduced into quantitative analyses of a data set, which oftentimes will make sense. And you can draw on data to predict values of, say, a health behavior or things like that based on other values. But that assumes that we already understand the full range of possible values that variable can take. And so oftentimes, unfortunately, what happens is when this is applied to race variables is that we get, we use other data to impute or infer race, for example, geolocation and surname or something like that. But as you can imagine, this works really good for certain groups, but pretty terrible for others. In particular, multiracial people are never imputed. Their race is never imputed. Studies have shown that the values generally approach 0%. Amani, go ahead.
Yeah, thank you for this incredible talk and just the paper in general for you and your co-authors. So you were explaining that there is a multiracial experience outside of a monoracial experience, right? Regardless of what that category is. And my question is, what, if anything, do we know about particular racialized experience among multiracial groups? So when you were talking about disaggregating the multiracial group, do we know anything about different kinds of racialized experiences depending on what the particular combination is?
Yeah, I mean, I think that there's quite a few, I think I hesitate to speak on behalf of other groups, and I feel like there could be an entire paper written specifically about this, like kind of the specific intersection of those racial identities and what that experience kind of entails. But in general, I think a lot of the commonalities have to do with sort of the othering that people experience from both of their parental racial groups. The othering, sort of like all the stuff that we talked about in terms of modern racism. But there are, as you mentioned, of course, definitely very specific intersections at those racial identities. And I think that are also even further intersectional based on geographic location, right? And so the experience of a Black and white person in Alabama is going to be very different than the experience of a Black and white person in Los Angeles, and vice versa, right? So I hesitate to like speak on behalf of everybody because I don't know those experiences, and I feel like I'd have to do more research. But geography, I think SEP, all these things that we know, and sexual orientation, all of that stuff kind of plays into unique experiences that are pretty well, I think, described in qualitative literature, but I maybe don't want to say them all here today.
Yeah, thank you.
Great. Thank you. Thank you so much. And thanks everyone for joining. We really appreciate it. I put a link to the paper in the chat, and we will make this recording available as well. And I can also share the slides. So thank you all very much. And thanks so much to Tracy for the outstanding talk. Really appreciate it.
Yeah, thank you all for joining. I really appreciate you and your support. Have a great rest of your day.
Have a great day, everybody. Thanks.